all of us are moving into the aging category.
Mm-hmm.
We're all getting older. We will all be there. So when you get there, if you're fortunate enough to get there, how do you want to be dealt with? How do you want to be taken care of? You are going to be one of those people who will need the support, potentially, of people who understand what it is you're going through. I think that's one way to get people understanding about the importance of it, because it's not a hypothetical. It's not people over there. It's you.
Hello, and welcome to 20-Minute Health Talk. I'm Sandra Lindsay. There is an old adage, growing older is a privilege. Today, I have the privilege of speaking with Michael Dowling and Dr. Maria Carney, authors of the new book, Aging Revolution: The History of Geriatric Healthcare and What Really Matters to Older Adults. They tell the story of geriatric medicine in the U.S. and highlight those who devoted their careers to easing suffering and improving the lives of aging adults. Before we jump into the conversation, here's a little bit more about our guest. Michael Dowling is president and CEO of Northwell Health. He has written several books prior to this, including his autobiography, After the Roof Caved In, and Leading Through a Pandemic, released in 2020 during the height of COVID-19. Dr. Maria Carney is Chief of Geriatric and Palliative Medicine and Medical Director of Post-Acute Services at Northwell Health. She also served as Nassau County Health Commissioner. Now, here's our conversation with Michael Dowling and Dr. Maria Carney. Well, good morning, Mr. Dowling, and good morning, Dr. Carney. Thank you so much for joining us today on 20-Minute Health Talk. And we're here to discuss a very important topic, the topic of aging. There seems to be so much in the news lately about aging and tapping into that fountain of youth, and everybody wants to get younger and younger. But you recently released a book, The Aging Revolution, and your messages are different. What inspired you to write The Aging Revolution? I'll start with you, Mr. Dowling.
Well, I think it's pretty obvious in one way. We have today 62 million people over the age of 65 in the United States. And this is not just a United States problem. This is an international. 20 to 30 years from now, that number will go from 62 million to about 82 million. So we know that as people get older, we in healthcare especially have to be equipped to be able to respond and be very understanding of this issue, but be able to put in place those policies and procedures as to what we do with the population that is getting older, especially since if you look at any hospital today, the population in the hospitals tend to be of older population compared to like 20 years ago. So part of the book is to give you a bit of the history, understand where we were, the successes that have occurred up to now, and then as a foundation knowledge, then to think about what we need to be doing going forward. So it's not meant to be the complete story. Mm-hmm. It's a big part of an ongoing process of discovery that we'll be undertaking as long as we're in these businesses. And every healthcare organization should take the situation very, very, very seriously.
Well, I fully enjoyed reading the book, appreciate the history. And Dr. Carney, you're very much a part of that history. But before we get into your place in that history, what inspired you to want to be a part of this book, of telling this story?
2 years ago, I received a call from Michael, and his office helped coordinate a meeting. And the directive was give a presentation on aging services at Northwell Health. We compiled a group of leaders in the system in this space, and we presented different aspects from delivering care at home, polypharmacy, longevity, function, all of different aspects of aging well, and models of care to deliver services to individuals. And from that meeting, which was supposed to be an hour, I recall having this incredible conversation back and forth of the complexity of aging. And for me, I think that was, I wasn't aware at the time, but that was the beginning of the creation of this book. And it became a back and forth of who should we interview in this space. And so each chapter was based on many, many interviews of leaders who have really altered healthcare for all, but it began with their dedication. We are really in an interesting point of healthcare change, and I think because of Michael's leadership in having this discussion, we could really push healthcare for all in the nation in the direction it needs to go.
So, Mr. Dowling, you wrote that we live in an ageist society. Can you define ageism and describe how it impacts the care older adults receive?
Well, there are a large cohort of people as they age that have unique circumstances, unique combination of circumstances that need to be appreciated and understood. It was not that long ago that if you talk to most physicians in leadership positions in health systems, they didn't recognize there was such a thing as geriatric medicine. The argument was they were just older adults, somewhat similar to all adults, without understanding the unique circumstances. This is why the field of geriatric medicine is very, very, very recent. The first department of geriatric medicine was in 1982. 1982 just is like yesterday. So we have come a long way since then, and this is why in the book we spend a lot of time talking about the role of Robert Butler, who initiated this whole process, and he was criticized for it. I met him a couple of times. He was criticized for it. He's a unique gentleman, but he created a whole cadre of disciples, and I would say I created the field. He did create the field of geriatric medicine. We need to do more in this area. Mm-hmm. But as Maria mentioned, we have to make sure that all practitioners of healthcare these days, whether you're primary care, whether you're a geriatrician or not, have to understand the uniqueness of what occurs as you get older.
Absolutely.
I want to just add to that. We're in unique times that we have to have this dialogue of how healthcare should change, what's important. And I have a patient who was 92 or is 92, came in and said he had a problem. He went to a doctor and they just said, no, you're 92. Mm-hmm. That was an ageist approach to him. He wanted to be seen, and he's a robust 92-year-old who's active in his community. He felt like he wasn't heard by healthcare. So we got him seen, evaluated comprehensively, and he was not turned away because he was 92. He was given an opportunity of treatment for things because he was thriving, robust. The risk of surgery was not as bad as someone thought. Everybody just looked at the age and not the big picture of his robustness, thriving, lack of frailty, which in terms of being ageist in healthcare, you can't just look at the number. You have to see their baseline function and look at their overall health and advocate. A child born in 1900 was expected to live to about mid-40s. The year 2000, 100 years later, a child born in 2000 expected to live into 80s. 2020, there's a potential to live into over 100, 120 years of age. We have incredible change of life expectancy across the globe. And we don't know how to deal with this growing population. We've never seen the healthcare decisions, and the healthcare system has not evolved to address this fully.
So how are you positioning Northwell to move forward?
I want Northwell to be the model of what an age-friendly health system should look like. And this gets to the issue which we talk about in the book about age-friendly health system. So what is it? And I think, quite honestly, that is a definition that will continue to evolve. Today, we are along on our way, and we have facilities in this organization that do phenomenal work, like at Glen Cove, has special designations, Glen Cove Hospital. But what we mean by age-friendly, I think we have to continue to work on because it has to be comprehensive and holistic. I'm always amazed that, you go to a hospital, you see an older gentleman and older spouse coming to the hospital in their car. Now, how far away from the facility do they get out of the car?
Right.
How do they get from the car to the facility? Who helps them get to the car for the facility? How do you handle parking? This is all part
How is
of
our
it.
signage in our hospitals?
Signage.
All of this.
Yeah, absolutely. And this is why we are holding a major conference here on December 3rd on aging and on, essentially, helping to further define what is meant by age-friendly. And this, by the way, one last comment on this. This applies to every organization, just not healthcare. Whether you're in the retail business, whether you're in the entertainment business, healthcare is has a unique role. But every organization, society has to appreciate that we increasingly will be dealing with an older population.
This is so fascinating, and a lot of people still don't know, Dr. Carney, what a geriatrician is. What do they do? Can you explain a little bit about that?
The specialty of geriatric medicine can be attained in a fellowship program after you've done an internal medicine residency or a family medicine residency. And it's a year, when I did it was 2 years. It's now 1 year fellowship where you learn not only about clinical care of older adults, and it follows the age-friendly framework, evaluating mentation, so that would be cognitive issues, memory, mood, like depression, anxiety, mobility, preventing falls, keeping people independent, rehabilitation, medications. And it really promotes healthcare delivery. And I don't think people realize that fellowship of geriatric medicine, while it addresses some palliative issues and primary care and longevity, it also teaches you and exposes you to all the models of care that individuals over 65 are traveling from: outpatient, inpatient, skilled nursing facility, hospice, house calls. And that's part of the fellowship. There are not many of us. It's a small group. Many become leaders in healthcare. And I think people don't realize that aspect of geriatric medicine. And then on the sister fellowship would be a palliative medicine fellowship that really focuses more on symptom management, helping people through crisis at any point, and then also hospice care.
As Dr. Carney said, we will never have enough geriatricians to care for the increasing number of our aging population. But instead, each physician, each person needs to look at aging differently. So how do we get that? You just mentioned a whole lot of things that we need to be thinking about.
Well, I would say it's continuing communication, continuing education. I think this book is a contributor to that. But I would also say all of us are moving into the aging category. Mm-hmm. We're all getting older. We will all be there. So when you get there, if you're fortunate enough to get there,
and it is a privilege to get there.
It is a privilege to get there. Then as you get there, and you say this to primary care docs, so you say to nurses, as you get there, how do you want to be dealt with? How do you want to be taken care of? You are going to be one of those people who will need the support, potentially, of people who understand what it is you're going through. I think that's one way to get people understanding about the importance of it, because it's not a hypothetical. It's not people over there. It's you. By 2034, there will be more people over 65 than there will be young people. Now, it raises a whole series of issues, not just healthcare issues, but economic issues,
Yes.
finance issues for the countryside, and not only here but around the world. And so we got to think a little bit differently. This requires that we educate people differently. Medical schools have to be a little bit different than how they approach this. Nursing schools have to be different about how they approach it. There are many more books that have to be written on this.
Yes.
This is just the beginning.
This, I think, is gives it's on the background, shows some of the progress we've made, and we have made progress. The fact that we are living so much longer is a wonderful credit to the success of public health and medicine and education and nutrition. Wonderful story. So in many ways, this is a story of success. It's not a story of failure.
Yes.
Because
But
how we handle the success now is the big challenge for all of us.
But I think this book is unique in that it really addresses healthcare accomplishments, leaders in healthcare who have dedicated their entire life to improving issues addressing older adults. And it also looks at the healthcare system. A lot of the books on aging out there are about what you can do as an individual to prolong your life, which is very, very important. But this looks at our role in society and some of really incredibly dedicated individuals that have not gotten the attention they deserve, that have really changed healthcare. And that's what I'm most proud of. We interviewed so many people that are just heroes and leaders of this revolution.
And when they took it upon themselves to become those heroes, there was a lot of opposition. Today, it's a little different. Today, there's more of an appreciation of it, but there wasn't when many of these people began. You know, they fought the establishment to promote the concept that there was such a unique field of medicine as geriatric medicine. And that's important.
You spent 2 years, about 2 years working on the book. Did you learn anything that surprised you?
What I learned really is moving forward and the changes in the last decade for Medicare. I knew this, but I did not know it as in-depthly as I've learned through this experience. Medicare has largely been a fee-for-service entity. Now, insurance companies have come into the Medicare space and created policies called Medicare Advantage policies. So it's a merging of Medicare, a government payer, and insurance companies. And soon, 70% of Medicare beneficiaries will have this insurance product called Medicare Advantage. That is changing how we are delivering healthcare. It's changing healthcare payments. And this is all happening very rapidly, and I don't know that the public fully appreciates this change. There's a lot of writings going on about this change that's happening, and I think we have to look very closely about this, what's happening with Medicare, Medicare Advantage, healthcare delivery, and how it affects the quality of care. In many ways, Medicare Advantage made identifying Medicare programs easier because these insurance companies have brokers that say you can have this, you can have drug payments and other services, which is easier to comprehend, so they bring people in. But it has not been shown yet that Medicare Advantage is actually saving money or improving quality. And I think that's the space we really need to look at closely, how it's helping the country, us as individuals, and the direction that's going in.
So then, what are your hopes for the future of aging in America, and what can listeners do to support positive changes?
First of all, I think there's hardly anybody out there that would listen to this that doesn't want to have a longer life and doesn't want to have a healthier life. So they should be supporting those programs and those initiatives that facilitate that. Become no more knowledgeable of what's going on outside their field, know what healthcare systems are out there, what hospitals and healthcare systems are doing that can be examples of how to do it better. So be an advocate, be an optimist, feel good about what we've done, feel great about the progress that has been made, and be an ambassador for making sure that everybody that is involved in this field is moving forward and doing it better.
The two chapters that I really look to in this book to help direct the strategy for health care across the nation is delivery of care at home and primary care. Primary care for older adults means that you have to be equipped with multidisciplinary teams, have access to a social worker, be able to spend time, deal with the multiple problems. We have the answers. There are leaders in both these areas of delivery of care at home and reinventing primary care. It does mean adjusting payments so that maybe it's not as much in the hospital, but that we focus in sites outside of the hospital, because there's a population that we can care for that can't access most doctors' offices, and they're using emergency departments as their primary care because that's the only way they can get in, using ambulances back and forth. So if we can focus, and it's 5% of the population in healthcare that is using 50% costs. If we utilize services in a way to help that population, we can improve their lives and we can adjust payments. So we know what to do. It just has to be a concerted effort. We see our emergency departments really struggling. They're very, very busy. And I think because we don't have those services in the right ratio right now in society. So those two chapters, I think, help give a blueprint, improving care at home and reinventing primary care. And our goal at Northwell is to provide the right care at the right time in the right place.
And to be the best at getting better.
Thanks again to our very special guests today, Michael Dowling and Dr. Maria Carney, authors of the new book, Aging Revolution, which is out now and available for purchase. One more note before we go. Remember to subscribe, rate, and review this podcast. Thank you for listening. Until next time, this has been another 20-Minute Health Talk.